Good afternoon, everybody. I'm Dr. Pratik Tambe, Chairperson for the AMOG's Endocrinology Committee. A very warm welcome to all of you, respected dignitaries and faculty, who have gathered here for today's program, which is themed on high risk pregnancy. We've done a lot of events in the recent past, over the past 6 months, under this theme of high risk pregnancy, and they've been very well received by everyone. We've had excellent feedback from the audience, and today's program, I hope, will continue that same tradition. Let me start by offering my gratitude. Next slide, please. To our AMOX president, Dr. Nandita Palchetkar. Madam is the immediate past president of Foxy, the current president of AMOX, and right since the time when she was the president of the Mumbai Society, she has always supported, promoted, and encouraged all of us juniors. And we wish to place on record our gratitude for all her support and encouragement throughout these years, including, of course, the past few months during the COVID pandemic when we've started this entire series of programs. Next slide, please. I'd also like to place on record my gratitude to our Secretary of AMOGS, Dr. Arun Nayak. As earlier, he's also been the president of the Mumbai Society. We've been closely associated with him since several years, and Sir is also somebody who always supports, promotes, and encourages all of us juniors whenever we have any academic activities in mind. Next slide, please. Here, I must also acknowledge our chairperson of ICOG, Dr. Mandakini Megh, the secretary of ICOG, Dr. Parag Piniwale, for granting us ICOG credit points for the entire series of programs, including today's program, which is accredited with one ICOG credit point. Today, we have two fantastic speakers, our state coordinator of AMOX, Dr. Amay Purandare, and the vice president of Foxy, Dr. Atul Ganatra, who will be speaking on two very important subjects as far as high risk pregnancies are concerned. And to take us through the proceedings, we have four very eminent faculty who are chairpersons. The first of these is Dr. Kiran Kurtakoti. Sir is the second vice president of AMOGS. He's been the chairperson of the MTP committee of AMOGS in the past, chairperson of medical education, research, and training for AMOGS in the past. Also served as the second joint secretary of AMOGS in 2009 and as chairperson of the MTP committee of Foxy from 2009 to 11. He has been instrumental in organizing several conferences and, of course, academic activities throughout his association with AMOGS and the recipient of several awards, including the Siuli Rudrasana Prize for Best Paper in Endoscopy and the CS Dawn Prize for Best Paper at AICOG in Chennai. We're very happy to have Dr. Kiran Kurtakoti sir here with us. Next slide, please. We are privileged to have with us Dr. Lakshmi Shrikhande, the chairperson designate of ICOG. She is the national corresponding editor of Jogi, which is the Journal of OBGYN of India, the official Foxy journal. She is the national corresponding secretary for EMWI as well. She's been vice president of Foxy in the past, founder, patron, and president of the ISOPAB Vidarbha chapter currently. Received the Nagpur Ratan Award at the hands of Shri Nitin Gadkari and received the Bharat Excellence Award for Women's Health. Also received several Foxy awards in the past, including the Merudara Hansotia Best Committee Award for her work as HIV/AIDS Committee Chair, which was one of the initial steps during which I actually came across her. And since then, our association has been going from strength to strength. We're really happy to have Dr. Lakshmi Shikhande here with us. Thank you so much, ma'am, for joining us.
Thank you, Pratik.
Dr. Vaidehi Marathe is currently the president of Nagpur OBGYN Society. She is the vice president of NARCHI for 2018 to 20, winner of the MS Signature International Award, member of several Foxy committees, chairperson of the state body of AMOG's Public Awareness Committee for 2020 to 22, nodal officer for the Family Welfare Committee as well. She has several distinctions to her credit as far as academia is concerned. And we're really happy to welcome Dr. Vaidehi Marathe on the AMOX platform, specifically for me as a chairperson. Thank you so much, ma'am, for joining us. I'd also like to welcome a very good friend and colleague, Dr. Chaitanya Shembekar. Sir has been a past president of the Nagpur OBGYN Society. He's currently the chairperson for the Infertility Committee of AMOX, also an executive member of the Maharashtra chapter of ISAR. When I was chairperson for the Foxy Endocrinology Committee, Sir was one of my committee members and worked very actively in the committee. He has several distinctions to his credit, including recipient of the Kamini Rao Yuva Foxy Orator Award, gold medal in MBBS Mukund Shastri Gold Medal, Khandwala Best Paper Award, orations in more than 50 societies, and of course, the list is endless. We're really privileged to have somebody as a distinguished personality like him to be here as one of the chairpersons for today's event. There's just a brief update. Today's first speaker was due to be Dr. Atul Ganatra, Vice President of Foxy. Sir is held up in an emergency surgery and will try and join us a little later. So we will have the second speaker first. And the second speaker is none other than the state coordinator of AMOX, my dear friend, Dr. Ame Purandare. What can I say about him? He's gone through the ranks over the past 2 to 3 decades in AMOGS as well as in Foxy. He served as the honorary secretary of AMOGS in the past, zonal coordinator, state coordinator now, and very soon we hope to see him as the vice president of AMOGS as well. But for his official and formal introduction and to take us through the proceedings for today, I hand over to the four chairpersons and request them to please do the honors. Thank you very much.
Dr. Vaidehi, you can introduce.
At
It's
the
really early, na?
outset, a very big thank you to Dr. Pratik Tambe for inviting us to be the co-chairpersons of this particular prestigious. I've known Amir since the past 25, 30 years, and Amir has been working phenomenally in Foxy as well as in Emox. He is a current consultant and OBGY specialist at Purandare Hospital and KJ Somaiya Hospital. He is the joint secretary, was the joint secretary of huge amount of work done by Amir along with our president, Dr. Nandita Palshetkar. He was the Food and Drugs Medical Surgical Equipment Committee chairperson of Foxy in 2015. He's the assistant administrator of Foxy Manyata project, and Foxy Manyata project is one of the key projects wherein Amox and Foxy has partnered with Manyata for accreditation of many of our small nursing homes. He is a member of the managing committee and mentor of the Youth Council of the Mumbai OBGY Society. He is the secretary. He was a secretary of AMOX 2014-15, zonal coordinator of AMOX 2015-19, state coordinator of AMOX currently 2020 to 22. And I hope, wish and pray that Ameya, you help me out whenever 2 years or 3 years from now, whenever I take over as the president of AMOX. I hope to see you in a good position along with me, working hand in hand for the betterment of AMOX and all of us in general. Thank you. And over to Ameya for his particular talk.
So before Dr. Amir starts, I just want to advise everybody that Dr. Vaidehi has taken time out from a busy schedule to be with us today. Madam has to leave by 2:30, so we would request her to please give us a few words of wisdom regarding this topic for today, the role of progesterone in RPL, before Dr. Amir starts his talk.
Thank you so much, Dr. Pratik. I would really not want to, pitch in between the important talk by Dr. Ame, my dear friend, and a person known to every one of us, every Foxian, I would say. So, actually, over to you, Ame. I request you to please start with your talk. Thank you so much.
Unmute, Ame, unmute. Thank you, Kiran, for those very kind and always encouraging words. It's a friendship which I cherish immensely. And I hope that just like Virat Kohli and Ajinkya Rahane have many a partnership which ensure that India win both home and abroad, I'm sure that I will definitely do my best when I get elected as second vice president of AMOX to be with you to lead AMOX to even greater heights than what we have right now under the visionary leadership of Dr. Nandita Palshetkar. I put on record also my sincere thanks and blessings from my senior colleague, Dr. Lakshmi Shrikhande, who's always smiling and supporting me in all my endeavors. I love always talking to her when I am in Nagpur, and also Vaidehi, who is a friend and a friend in need is a friend indeed. She's always there, and I'm just amazed at the creativity and the way she has taken Nagpur society in her presidentship. Even though there was the challenge of COVID, she just showed that where there is a will, there is a way. And thank you, Pratik, for inviting me here this afternoon. And I would like to thank all of you all for being here this afternoon, and most importantly, for supporting me in this campaign of mine of leading to the second vice president of AMOX. It's been really a memorable journey of last 30 years, and I wish I can take it further to ensure that the women of Maharashtra are served better by us proud and compassionate gynecologists. So I'll start my talk. Pratik, if I'm allowed screen sharing.
Yes, sir, you can go ahead.
So my talk is slightly on a different note today. It's going to be about the role of progesterone in RPL. It's what I simply put forward as nature's negotiation. Be it in the animal world or in the human world, pregnancy is a memorable event. It is an eternal divine bond between the mother and child, or the mother and the fetus inside. And therefore, the mother adapts, accommodates this fetus to ensure that she brings in happiness and joy, not only for her, but also her partner or husband, but the family. And if she is able to give us good progeny, obviously the nation and the world will have many such supermen or women who are born. And therefore, pregnancy is a very, very important event. Now, why do I call it negotiation? Chanakya said in Arthashastra that negotiation is a dialogue between two or more people intended to reach an understanding, resolve a point of difference, or gain advantage in outcome, to produce an agreement, to craft outcomes to satisfy various interests of those involved. I think perhaps he also meant that this is the unique bond or the unique relationship between the growing fetus and the mother. To put it more scientifically, R.G. Schell identified 5 responses to negotiation. They included accommodating, avoiding, collaborating, competing, and compromising. And you will agree with me, these are the various responses that the maternal physiology is adapting itself for the need of the growing fetus. Now let's move on to scientific concept of alloimmunity. Alloimmunity is nothing but an immune response to foreign antigens or alloantigens from members of the same species. The body attacks especially transplanted tissues and even the fetus in some cases. And hence the alloimmune response results in graft rejection, which results in deterioration or complete loss of function of the graft or the transplant. Now, why does this occur? It occurs because of the difference between the products of highly polymorphic genes, primarily the genes of the MCH complex of the donor and the graft recipient. These products are recognized by the T lymphocytes and other mononuclear leukocytes which infiltrate the graft and damage it. There are 2 unique concepts, very different. One is to accept, the other is to reject. And Sir Peter Medawar, the father of transplant medicine, when he received the Nobel Prize in Physiology and Medicine in 1960, summarized it very beautifully. He said the human mind treats a new idea the same way the body treats a strange protein. So our response is rejection. It rejects it. And there comes the need for negotiation. There comes the need for change. There comes the need for adaptation. There comes the need for acceptability. So the fetus is an allograft. Throughout pregnancy, genetically foreign small allogenic fetus and the placenta continuously evade the maternal immune responses. It's like a dodge. It's like running away and ensuring survival. Fetal survival requires significant regulation of the maternal immune system, but not such as to compromise immune protection. So on one side, there is regulation, change. On the other side, there is a balance to maintain that the immunity is still there and the woman doesn't go into an immunosuppressive state. Now, we all know that recurrent abortion is a major challenge. It is a traumatic event for the couple and also for the clinician. And if we go to study into the causes, 50% of times we are able to explain the cause for recurrent abortion. It could range from endocrine causes, anatomic, genetic, infectious, autoimmune like anticardiolipin antibodies. But friends, in 50%, we all have to confess that we are not able to explain the cause for recurrent abortion. And probably it is because of a deficient immunosuppression. In other words, increase in Th1 cytokines and decrease in Th2 cytokines, tipping the balance towards a rejection from an acceptance. Do genes control this? Yes, they do. We have now reached the level where we can pinpoint gene expression. And in this paper from Korea, they very clearly said that aberrant gene expression was associated with recurrent pregnancy loss. In some pregnancies, the mothers recognize the foreign paternal antigens and set up an immune rejection reaction to them, which causes an abortion. Unfortunately, in habitual abortion, this reaction gets repeated every time the woman is pregnant, and hence she has a bad obstetric history or recurrent pregnancy loss. However, in the healthy pregnancy, the fetus is not compromised by an allogenic immune response. In this pregnancy, there is a crosstalk between the pre-embryo and the mother-to-be, which starts immediately after fertilization. Mind you, this event is all beginning much before the actual pregnancy test comes positive, and what the mother is doing is creating an environment which will be protective, which will be conducive, and which will be favorable to the growing fetus. Who does all this? Friends, it is progesterone, our friendly hormone, our hormone of pregnancy. It is the modulator, it is the negotiator, it is the accommodator. So, from a rejection, it ensures that it changes the maternal response to one of protection. The maternal immune system gets prepared preconceptionally. We all have realized the importance of preconceptional counseling, but also preconceptional priming of the immune system is equally important for embryonal survival. Epidemiological observations have shown that in preeclampsia, most likely in the first pregnancy and in women undergoing IVF with donor semen, compared with those with partner semen, there is the supported view that the risk is attributed to assumed minimal pre-exposure to the paternal antigen. And hence, preconceptional preparation is absolutely essential. In 1999, an interesting paper came which was written by Clark, and it talked about why your mother rejected you. And he put it simply, why did your mother reject you, one asks, while peering down a microscope tube at the remnants of a spontaneously aborted embryo. There are many proposals as to why she did not, and if she did not, but until we know why she rejected you and how, we will never know the answer. The details of this paper went on to say that there are certain immunogenetic determinants of response to an environmental selective pressure expressed at the uterine level, which results in this rejection. And I will simplify this rejection process and this acceptance process in the next few minutes. Look at this particular balance. On one side, you have the balance of the Th cytokines, which if dominated, lead to rejection. And the Th2 cytokines on the other side, if they dominate, it will be a tolerance, it will be an acceptance. Hence, the immune system has to be altered, has to be modified so that the Th2 dominance is prevalent in early pregnancy and continues throughout pregnancy to ensure survival and growth of the pregnancy right up to delivery. There are three ways by which immunological pathways cause rejection: antibody mediated, Th1 cell mediated, and NK cell mediated. NK means the natural killer cells. Whenever there is an allogenic reaction, there occurs an abortogenic shift. What do I mean by abortogenic? It shifts towards an abortive process. This occurs because of symmetric binding of the antibodies, which lead to activation of the complement, leading to a dominance of the Th1 cytokines and activation of the NK cells, leading to LAK cells, which is co-mediated by interleukins and tumor necrosis factor. In other words, there is a dominance and an activation of embryotoxic antibodies. Friends, look at these two pictures. They look extremely graphic. They look very beautiful. In the first one, you can see everything is stuck to each other. The binding is beautiful. You can't see a gap in between. On the other hand, on the other side, you see a gap in between. The right and left are not bound completely. Let me tell you the significance of this. Binding surface of the antibody is symmetrical to the binding surface of antigen. We've always been told that the antigen and the antibody, they bind to each other completely. If this symmetric binding occurs, it leads to a response. And if there is a perfect binding that occurs, it will lead to the activation of the complement cascade, leading to the production of the embryotoxic antibodies. So what progesterone does is that it prevents this beautiful symmetric binding. It keeps the mother and the fetus so-called at a distance, the antigens, and therefore ensures that the fetus continues to grow and the mother accepts the growth of the fetus. So this is what happens. There is asymmetric antibodies, and therefore there is no effector function, no cytotoxicity, no phagocytosis. The immune system becomes dominant towards the Th2 type of immune system or response, and there is decrease in natural killer activity. All in other words, there is masking of the fetal antigen and continual survival of the fetus. Now, this occurs all at the feto-maternal interface, namely the decidual VG1 CD556 cells and the peripheral mononuclear cells. So there is where all this occurs. Who does all this? The magician is progesterone-induced blocking factor, or PIBF. PIBF ensures that the antibodies don't bind symmetrically, ensures that Th1 is allowed to grow and to become dominant at the expense of, Th2 is allowed to grow and become dominant at the expense of Th1, and the natural killer response of the cells is suppressed. In other words, the fetus is allowed to go. So who is this magician PIBF? It's a protein produced after activation of the progesterone receptors, produced by the CD56 cells and the peripheral blood mononuclear cells. It induces asymmetric antibodies which are non-cytotoxics, supports Th2, reduces the activity of the natural killer cells, and hence is the key to embryo survival. Now let's look at this particular study way back in 1990, where they evaluated the progesterone receptors in pregnancy lymphocytes, and they found that in normal pregnancies, the progesterone receptors were greater as compared to the aborters. In other words, greater the progesterone receptors, greater the chance of production of PIBF. If you look at this particular study, you will find that in those patients who were treated with RU486, which is a progesterone antagonist, the progesterone receptors get blocked, and as a result of which the embryo results in an abortion. And lack of PIBF leads to the formation of asymmetric antibodies, as you can see from this, in pregnancies which are not treated as compared to those where there is an anti-PIBF and those with RU486. So here you can see the critical role that PIBF plays in embryonal survival and immunomodulation. This is a rat uterus. On one side, you will see normal serum which is injected and which has caused growth of many an embryo in the rat uterus. On the other side, an anti-serum to PIBF which blocked the PIBF, destroyed the PIBF, was injected, and you can see unfortunately there is no growth of the fetus on the other side. It is an important thing that we must understand, that PIBF maintains pregnancy. Enough of scientific research. What is the benefit of scientific research if it is not so useful in clinical medicine? And therefore, let me tell you whether evidence-based medicine supports this cellular or even experimental research. From 1994 onwards, we are regularly seeing that yes, progesterone is beneficial in recurrent pregnancy loss. The American Journal first reported that progesterone supplementation increased leukocyte and T cell concentrations in the human endometrium. The Biological Reproduction Journal said progesterone supplementation exerts a protective effect by quantifying that it is the Th2 based immunoprotective response which is responsible. And way down in 2006, they went on to say that progesterone probably acts as an immunosuppressant, blocking T helper Th1 activities and induces release of Th2 cytokines. What does Cochrane say about all this as far as preventing miscarriage is concerned? They went on to say in their rather skeptical way first that there seems to be an evidence of benefit in women with history of recurrent miscarriage, as Cochrane usually keeps a very balanced view or a very non-committal view in their initial presentation. But subsequently, they went on to say that treatment for these women may be warranted given the reduced rate of miscarriage in the treatment group and finding of no statistically significant difference between treatment and control groups in rates of adverse effects suffered either by the mother in the available evidence. So they went on to propose that where you don't know what is causing recurrent miscarriage, it is worthwhile to start progesterone, because unfortunately we cannot determine the levels of PIBF in human blood as yet. So therefore, there is no harm in starting progesterone. It is proving to be beneficial, giving a hope of pregnancy and a carry home baby in these patients. Now, let us look at the direct cause and effect relationship. If we give progesterone, as seen in this study published in 2001, you will find that the PIBF levels start increasing. There is a direct cause and effect relationship, and that gives the rationale for giving progesterone in pregnancy. On the other hand, if you do not give progesterone, okay, then what happens? You find that as the levels of the mitogen increase, that is an anti-progesterone, the levels of tumor markers causing an abortogenic shift like IFN gamma go on increasing, as you can see in this particular group, that definitely progesterone is key to survival in these studies, and that is why progesterone, if it is given, will suppress the Th1 cytokine. As you can see, it has been suppressed in the group where progesterone has been given to minimal levels as compared to those where it is not given, it is pretty high. What about Th2? You will see here that where Th2 is given, where progesterone is given, the Th2 cytokine response is much greater, and therefore progesterone definitely causes this immune shift to a favorable immune shift as compared to no supplementation of progesterone. So what's the twofold effect of progesterone? One, progesterone induces PIBF, thereby upregulates the Th2 cytokines, causes asymmetric antibody production and decrease NK cells. And the other important role is that it directly upregulates Th2 cytokines and downregulates Th1 cytokines. Let's look at the two common progesterones that we use in clinical practice, and let's compare them head to head as was first described in the legendary B.N. Chakrabarty's trial, which was published in 2005. Dr. Chakrabarty said that I have compared vaginal micronized progesterone to oral dydrogesterone, and my results indicate that the viable delivery rate is 22.8% versus 24.1% in the two groups, and the abortion rates are reduced to 8.3% and 7.26%, and these are similar in both the groups. So take your pick, both are useful in this particular subset of patients requiring progesterone support in recurrent pregnancy loss. To put it simply, there are multifold actions like I told you. It begins with preparation of the endometrium, it begins with the suppression of the immune response, and it also helps in modulation of the immune response from a rejection to an acceptance to a progression via the PIBF, and this is what Schindler summarized in his paper in 2004. Now, it is particularly evident and exaggerated if there is a luteal phase defect, and here is where progesterone would definitely be needed, because if the endometrium is not properly prepared, you, my friends, like Dr. Lakshmi Srikhande, like Dr. Pratik Tambe, Dr. Chaitanya Shembekar, will definitely agree that a bad endometrium is one of the important causes for lack of embryo implantation, leads to infertility, and many a times recurrent IVF failure as well, and they ensure that the luteal phase is adequately supported by even high doses of progesterone. Which progesterone, so finally, we should use? We have a choice: injectable, vaginal, and oral. Injectable is available as intramuscular and subcutaneous. They do produce sufficient secretory transformation of the endometrium, but it can, and we all know, causes injection site pain, skin irritation, inflammatory reactions, and abscess formation. Vaginal progesterone is well tolerated with adequate endometrial secretory transformation. There is transvaginal use of progesterone can cause, however, discharge, vaginal irritation in some patients, and discomfort while administration. Oral, we all agree, is the easiest route of administration, generally most acceptable to the patient, and they prefer it over either injectable or vaginal routes. But whenever we are deciding which progesterone should be used by the patient, there are two important thought processes that we must keep in mind. As doctors, we want that progesterone route to be beneficial clinically to the patient, so we should have evidence. It should be efficacious. It should be safe without side effects, and results should be and it should translate into favorable results as far as our clinical practice is concerned. For the patients, on the other hand, their criteria are convenience, ease, results, availability, and cost. These are points that we also need to keep in mind and make a solution which is cost effective as well as clinically effective to the patient. Keeping all this in mind, I was an important part of the FOXI Food and Drug Committee in 2015, where I was the committee chair, and we brought out the first FOXI position statement on the role of progesterone support in luteal phase in the first trimester. A lot of key opinion leaders from all over India met together in Goa, discussed, debated, deliberated, and finally came to a consensus that progesterone should be given in recurrent pregnancy loss. Before I put forward what they had to say, let me tell you what the meta-analysis and guidelines across the world have to say. The two main studies, one from abroad and one from India by Dr. Ashok Kumar from Delhi, have shown clearly that progesterone reduces the miscarriage rate in patients of RPL. Whether it be dydrogesterone, whether it be micronized progesterone, both have found to have sufficient benefit. It was proven firstly in Haas and Ramsay's meta-analysis and Karp's EPIC meta-analysis in 2015, which led the European Progestin Club guidelines for the treatment of threatened miscarriage to say that in patients who present with a clinical diagnosis of recurrent miscarriage, which they defined as 3 or more, there is a reduction in the rate of miscarriage with the use of progesterone. FOXI went on to say that in recurrent miscarriage, you can give progesterone orally or vaginally. Orally, you can give dydrogesterone, and vaginally, you can give micronized progesterone. I told you, you need to ensure that the patient is comfortable, it is convenient, compliant, and it is cost effective. You can take either pick of these. Both of them are found to be useful. Whenever we use a drug, not only are we deciding its utility based on its efficacy, but the other side should be that no drug should be unsafe or harmful to our patients. It should be tolerated by our patients. And 4 important publications over the last decade have clearly looked at the safety and tolerability, and they have found that progesterone support in the luteal phase and in the first trimester, whether it be for recurrent pregnancy loss or whether it be for threatened miscarriage, is found to be safe with no harm for the growing fetus. Also, FOXI seconded that, and they went on to say in their position statement that no statistically significant difference in congenital anomalies have been seen over the years between newborns born of mothers who received progesterone and those who did not. So, progesterone is effective and progesterone is safe. Friends, let me rest the case of the curious case of progesterone. We all agree progesterone is an essential hormone in pregnancy. It is widely used by all of us with the sole intention to improve and prevent threatened miscarriage, recurrent miscarriage, and now even preterm labor. Progesterone acts via PIBF, the magician, on the endometrium, exerting an immunomodulatory and an anti-inflammatory action, ensuring maintenance of pregnancy. And supplementation with progesterone exhibits a positive benefit risk profile by improving live birth rates in those women with RPL. To end, I quote Charles Darwin, whose Origin of the Species recently completed its centenary, and he said, "It is not the strongest of the species that survive, nor the most intelligent. It is the one that is most adaptable to change. And pregnancy is one such immunoadaptive change which ensures fetal growth, fetal survival, and the birth of a healthy baby, leading to happiness in these women's lives who come with recurrent pregnancy loss." Thank you so much for a patient here.
Thank you, Ameya, for that lucid talk. Any questions to Dr. Ameya? Dr. Lakshmi, Dr. Sarada, would you like to
Thank you,
ask?
Ame, for explaining the role of progesterone in recurrent pregnancy loss in such a simple way for the benefit of our delegates. And I must say that all our delegates, they should go in detail about the Foxy statement on progesterone in 2015. It is uploaded on Foxy website, or you can just download it from Google, and it will help you in our day-to-day practice. But I think nothing has changed since last 5 years, Ame, in that position statement, because we all agree that progesterone is needed, whether it is dydrogesterone or natural progesterone. But there are a lot of studies in favor of dydrogesterone because of its additional immunomodulatory effect over the natural micronized progesterone. And our Indian population is more comfortable with the oral route as compared to vaginal. So here again, dydrogesterone scores over. Very well done, Ameya. Beautifully explained. Thank you so much.
Any other comments from other co-chairpersons? Well, fantastic presentation, Ameya. Thank you for the talk. And we hope, we should pray that you be there with us always in the times to come. Thank you, Pratik, for inviting us.
किरण और अमेय की, हाँ, जय वीरू, वीरू, क्या नाम दूँ तुम लोगों को?
Okay, Jai Viru ji. Jai Viru ji, no problem. I have no issues with that.
Lakshmi Madam, seeking your blessings and support for my AMOG's Vice President candidacy. As you always bless me with your Ashirwad, looking forward this time as well.
Okay, you know that goes without saying with you. And Kiran with you also, huh? You have asked for only Amey's support during your presidency, but we are with you, AMOGs. We want you to skyrocket.
You want Mata Lakshmi for us?
Yes.
Thank you so much.
Thank you, Pratik, and thank you all.
Thank you very much, respected chairpersons, and that excellent talk, Dr. Ame Purandare. We have no questions so far in the chat box.
Yes, explain it such a beautiful way, very simple way. So audience, they have got answers to all their queries.
Precisely. And we have nearly 500 members who are logged in today. We are still waiting for Dr. Atul Ganatra sir to finish his emergency surgery and log in. So while we are waiting for him, I think we should go ahead and start the panel discussion.
Alka ma'am.
Yes. My net connection was weak.
Eagerly looking forward to coming to Nagpur, okay,
Yeah.
to enjoy your hospitality at your next conference.
She has already invited me.
She is taking over as NOGS president from 1st of April.
I know. I have told Vaidehi that I am going to arrive in Nagpur during Alka ma'am's presidency. Alka ma'am, don't be partial to only Pratik. You have to invite me as well and Kiran as well. Okay.
All are invited very much, and Vaidhi is going to continue as president in my tenure also.
Point well taken, Ame.
Thank you very much, everybody. We'll start the panel in the odd chance that maybe Dr. Ganatra will join in later and maybe we can have his talk after the panel. So can I request Shrimon from Science Integra to please display the CV slides for our panelists? So we have a host of eminent, senior, respected OBGYNs as panelists for today's panel, which is on first trimester bleeding. I am the moderator. First of the panelists, as you have seen, is Dr. Alka Mukherjee, madam. She is the director of Mukherjee Multispecialty Hospital. She is the Honorary Secretary for International Council of Human Rights, Honorary Secretary of NARCHI, the Nagpur chapter, Honorary Secretary of AMWN, Honorary Secretary of ISOPAB, member of several organizations, and as you can see, she'll be taking over as the president of Nagpur OBGYN Society next year. She will also be the president of Narchi Nagpur chapter next year. I think it's going to overlap. No, it's I think a couple of years later. Lovely to have you with us. Thank you so much, ma'am, for accepting our invitation. Next slide, please. Shimon, next slide, please. Yeah. We also have with us Dr. Rajasi Sengupta. Madam is a consultant OBGYN at the Sengupta Hospital and Research Institute, which is in Nagpur. She is currently the secretary of the Nagpur OBGYN Society, and we are really happy to have her with us today. She has several awards to her credit, including the FICOG. She's presented paper at the FIGO World Congress, poster at UFOXY, delivered the prestigious Yuva NOGS oration in 2017. She's won prizes for her poster presentation and delivered several talks at national and international conferences. Welcome, Dr. Rajasi, madam. Thank you so much for joining us. Next slide, please. We are also privileged to have with us Dr. Swati Sarda. Madam is the director of Ketki Nursing Home at Dantoli in Nagpur. She is the president of JCI Nagpur Medicos and a visiting obstetrician at the Nectar Critical Care and KRIMS Hospital. Her special interest is in high risk obstetrics, PCOS awareness and management, infertility, and laparoscopy. She has several distinctions to her credit, including 5 publications in national journals, and she's a member of the National Academy of Medical Sciences. Thank you so much for joining us, ma'am. Next slide, please. Dr. Ritu Dagan is a director at Integra Specialty Clinics in Nagpur, consultant also at the Nelson Mother and Child Care Hospital at Dantoli in Nagpur, postgraduate diploma in medical legal systems from Symbiosis, diploma in emergency obstetric care from Sweden, ex-associate professor at Sevagram, master trainer for EMOC, which is being carried out by GOI. Lovely to have Dr. Ritu with us. Thank you so much for joining us. Next slide, please. Dr. Asha Jain is the president of the Raipur OBGYN Society from May 2018 till date. She's also president of the Rotary Club of Raipur North, elected member of the Chhattisgarh Medical Council, secretary of the IMA Raipur for 2 years, medical director of Cancer Prevention and Relief Society of Raipur from 2003 onwards, several other important distinctions to her credit. It's lovely to have Dr. Asha Jain back with us. Thank you so much, ma'am. We look forward to having your views during the panel. Next slide, please. Dr. Kiranmay Devineni is an associate professor at Usmania Medical College in Hyderabad. She is currently the vice president of the Hyderabad OBGYN Society 2019 to 20. She's been scientific convener for AICG 2011, which was held in Hyderabad. Also a recipient of the Kamini Rao UFOXY Orator 2013, national coordinator for MEDA ICOG PGCME in 2016, secretary of OGSH in the past, coordinator for the Dhira campaign, Violence Against Women, which is coordinated by Foxy along with FIGO, ICOG, and OGSH, and so many other important distinctions to her credit. Thank you so much for joining us, ma'am. Next slide, please. Dr. Kaveri Shaw is a very eminent personality from Jabalpur, and she has a fellowship in minimal access surgery from Hyderabad, fellowship in gynec oncology and robotic surgery also from Hyderabad, senior consultant at the Shalby Hospital in Jabalpur. She is currently the secretary of Jabalpur OBGYN Society, master trainer for various different programs, including the tubal ligation training of trainers. She's also occupied several important posts in the Jabalpur OBGYN Society and is an ex-consultant in gynec oncology at KIMS Hospital in Hyderabad. Lovely to have you with us, ma'am. Thank you so much for joining us. If I may be allowed to share my screen. So I presume I'm audible, and I'm presuming that the screen is also visible. Requesting all the panelists to please unmute themselves and keep their video on, because I usually rely on visual and audio cues to ensure that I don't miss any of the panelists. So this is our simple and straightforward panel, which is on first trimester bleeding. Welcome to all the panelists. I usually have just a couple of simple rules when we have a panel. The first is that I would wish that the panelists speak more than I do, and the second is that please avoid speaking in overlapping fashion. Raise your hand and you will be asked to speak. A willingness to be puzzled is a valuable trait to cultivate from childhood to advanced inquiry, the American author Noam Chomsky says. And when we talk about first trimester bleeding, there is so much more to talk about besides the usual threatened miscarriage. There are so many other reasons for first trimester bleeding, which we hope we'll try and cover in an evidence based fashion in today's panel. So let's start with the whole problem, how it starts. It starts because there are so many confusing definitions. And those of us who have studied OBGYN over the past 2 to 3 decades will realize that some of these terms have come, they have gone, they've come back again, they've been revisited, they have been reshaped, and there are so many confusing and overlapping terminologies. I would request each of the panelists to take, I think we have 7 panelists and there are 7 terms here on this slide. So each of you can take one of these terms, define it for us, and that would be a very good way for us to get started. We'll start with Dr. Alka Mukherjee, madam. Are you there? Please unmute yourself, ma'am. Shriman, can you unmute everybody, please? I think they're facing difficulty unmuting themselves. Yeah, perfect. Yes, ma'am. Please go ahead.
First of all, let me start with the early pregnancy loss. We can here very well say that early pregnancy loss is defined as a non-viable intrauterine pregnancy with either an empty gestational sac or a gestational sac which is containing an embryo which is without a fetal cardiac activity.
Or could we say that it's a pregnancy loss which occurs in the first trimester? Is that also
within
a very simple?
first 6 to 7, yeah.
Okay, that's a very easy non-medical definition of what is early pregnancy loss.
Yeah.
Okay, let's take Dr. Rajyasree Sengupta, ma'am. What do you think is an embryonic pregnancy?
Hi, Pratik. I think an embryonic pregnancy is something where we get an empty amniotic sac. Say on sonography, you are looking at a sac diameter of about 2.25 millimeters or so, and you still don't find any fetal pole. Then you could safely label it as an embryonic.
Perfect.
Means absence of embryo, a pregnancy that is not showing any embryo.
And in
In
the good
olden
old
days, I
days,
think it was also roughly labeled as a blighted ovum.
absolutely.
But today we
Absolutely.
stick to the more specific scientific term of an embryonic pregnancy.
Perfect. Fantastic. Can we have Dr. Swati Sarda? Can you tell us something about embryonic demise?
Yes, sir. Hello, sir. Embryonic demise can be said then when the CRL measures more than 7 millimeter and there is no cardiac activity seen on ultrasonography. That I think we can call it as embryonic demise.
Okay, perfect. That sounds good. Dr. Ritu is with us. What is a non-viable pregnancy in the context of first trimester bleeding?
Non-viable would be something if maybe previously you had, like Rajyasree mentioned, a gestational sac of more than 20 mm without any yolk sac or evidence of a fetal pole. We know that it's not going to grow.
Or if it has grown further, then there's an absence of cardiac activity.
Cardiac activity previously there was, and then
Yes.
maybe there is an absence of cardiac activity in the follow-up scans.
Perfect.
So that would be a non-viable pregnancy.
Perfect. Excellent. Dr. Asha Jain, madam, spontaneous abortion?
So spontaneous abortion is like a miscarriage where conception was diagnosed and then it has been lost. That is a spontaneous loss without any, medicine or anything. It is a loss where it was previously documented as present.
Absolutely.
That is
So
a spontaneous.
you have proven that there was a pregnancy and then later on it, for whatever reason, could not continue. And Dr. Kiranmai is with us. I think she's traveling. I hope she has good network. Threatened miscarriage? No, I think we've lost her. So I think Dr. Kaveri, just to get you warmed up, threatened or incomplete abortion, anything you would like to add? These are the easiest ones out of that entire list. Please unmute yourself.
When there is a threat to the baby. When there is a threat to the...
Threatened abortions are when we are getting a pregnancy live and there is some bleeding or bleeding tendency has been complained by the patient and we notice it also in ultrasound on somewhere, then it is but the pregnancy is live. Cardiac activity is
If I
So it is
may,
the
if
need
I may venture to say that maybe threatened miscarriage is the working diagnosis for all first trimester bleeding.
or first trimester.
Until you do further investigations and until you have more background history, previous
Yeah,
ultrasound, current ultrasound, that is when all the other terminologies is coming to force.
is coming.
So, for all
And
practical purposes, threatened miscarriage is the first stop in our entire diagnostic pathway. Yes, ma'am. Sorry, I interrupted you. Please go ahead.
sir, and complete when patient is having a bleeding and all, and she has actually conceived, and previous records were saying that was pregnant, but presently when she has come and we have investigated and we have found that there is no sac or cardiac activity inside the cavity, so it is a complete abortion. There is no sac inside. If it is in on the way to come out from the cavity, then it is incomplete, and then we have to proceed for the further management.
Okay, that sounds good. And I'll just add to that entire laundry list by saying that there are two new terminologies. If you read some of the newer guidelines and the research papers, there are two terms. One is pregnancy of unknown location and pregnancy of uncertain viability. These two terminologies are now being used more frequently as compared to the older terminologies which we just went through. For all practical purposes, us old timers usually still use the old terms. We are not so politically correct in trying to use new terminology, but it's worthwhile knowing that there are new terms also. So now let's come to the most important question, which will actually answer a lot of questions for the clinical cases that we are going to start covering in just a couple of minutes. That everything usually revolves around the ultrasound findings of this patient when she comes to us with first trimester bleeding. And there are certain specific ultrasound criteria. Some of you have already mentioned these. Just for repetition, can I ask Dr. Kiranmay, who has not had a chance to speak so far, can you tell us if there are any specific ultrasound criteria which will
Yeah.
tell you that this pregnancy definitely is a non-viable pregnancy and cannot continue?
Yeah, definitely. I think the 2012 Society of Radiology Ultrasound Conference, which is quoted very widely and which is I think mostly acceptable. So in that there is definitely criteria which are diagnostic of non-viable, where we can definitely tell the patient and ourselves. That is one is CRL of 7 mm, then gestational sac diameter of 25 mm without any embryo. Then
Absolutely.
after the yolk sac appears, then the failure of the gestational sac to develop embryo with heartbeat, that is 2 weeks, 14 days after that. And if there is a yolk sac, I think it is 11 days. These are the four definite criteria. Again, as you have said, pregnancy of uncertain viability or where we are not sure, the criteria lie in between, like less than 7 mm, and then all these things. I mean, 7 to 13 days, and then 7 to 11 days. Then I think yolk sac diameter of 5 mm or more. There's very many very clear criteria available on the, you know,
Absolutely.
internet.
Absolutely.
And these are the
Thank you so much.
Society of Radiology uh, ultrasound conference, something 2012.
So just to give
Even
you a
ACOG committee opinion also quotes this.
absolutely
The
correct. So just to give you a perspective, 25, 30 years back when I was a resident, I used to always wonder why the radiologists sit on the fence and say, okay, repeat a scan after 7 days or 10 days, some arbitrary amount. Somebody would say 7 days, somebody used to say 10 days, another radiologist would say 14 days. And then later on, when I went back to the books and read, I found out that you need to have two different scans done at least 1 week apart,
yes,
and then you would be able to identify without any uncertainty that this pregnancy was viable or non viable. And to avoid those clinical situations where you erroneously terminate a viable pregnancy, the radiologist had to sit on the fence. This is an important concept for us to grasp. That is why there are a lot of, you can see this middle column where it shows you a lot of
yes,
different
suspicious.
criteria where it is suspicious. This is where the radiologist will sit on the fence and will say, okay, repeat it after 1 week. But if you have the findings in that last column there, then you don't need to repeat the scan. I'm harping on this because many a time when a patient comes to you with bleeding, often she comes to you for a second opinion or a third opinion. Somebody has told her that this is not going to grow further. She's come to you in the hope that maybe you will say, ha, theek hai, we'll try for 1 week, 10 days, we'll repeat a scan again. But if you have these findings in that last column, then probably this pregnancy is not going to grow further and you're not going to gain anything. You are erroneously misleading the patient if you are trying to hold on in the hope that it is going to continue. Let's go to the clinical cases. Enough of theory. I don't want to talk too much about theory. I want to talk about practical situations. So the first case is a 32-year-old lady. She's presented in accident and emergency. Her last menstrual period was 8 weeks ago. She had irregular cycles. Previously, every 2 to 2.5 months, weight was 75 kilos. After a lot of diet and exercise, she's lost about 10 kilos, but still she is now 75 kilos. Now she's come to you with cramping pelvic pain. Emergency ultrasound was done. There's a 6 peak sized intrauterine sac. Cardiac activity is seen clearly, but there is a large subchorionic bleed, which is 1.5 by 1 centimeter in diameter. Let's start with Alka, madam. How would you like to tackle this patient? What advice would you offer her?
First of all, I will settle the diagnosis. She is an elderly primigravida who conceived after a weight loss. Means she is a high risk patient to begin with. That is threatened abortion. We should reassure the patient about, tell about the risk of abortion, properly explain to both the partners and the family members. Along with that, I will advise her the bed rest for her physical well-being, tender loving care for her emotional well-being. I will ask her to avoid stress, and at the same time, simultaneously, I will try to rule out the maternal general diseases like diabetes and hypothyroidism at the age of 32 years and other infections, and will like to treat them accordingly. And the most common cause in these patients, it is the luteal phase deficiency. Here I would like to use progesterone in the dose of 200 mg QID, that is a total of 800 mg. I did a study on this particular molecule when it was launched. Utrogestan was the name of the progesterone. That time I used to use that 800 mg, and I got fantastic results. And along with that, I would like to put my patient on endocrinal support, like logical support will be the SCG to support the corpus luteum function. Then avoiding the environmental toxicants is again very important. And if nowadays it's very common that APLA syndrome, if there are antiphospholipid antibodies are present, I would like to put
So
my
this is the
patient on low
primigravida.
doses.
Let us reserve the discussion of APLA a little later. Everything
Yeah, but
else,
sir,
I
she is
very much
elderly primigravida if there is
Not
history
early.
of SLE.
true. So here, I would very much agree with everything else you said. Now, an important question that often needs to be answered is whether this patient warrants admission. Are we going to give her something special when she is admitted in the hospital, which she cannot receive at home? Dr. Asha Jain, madam, what are your thoughts on this issue? Should we admit all patients with bleeding, or should we reserve only for
So
certain
actually,
important
the
patients?
data shows that 30% pregnant women bleed in the first trimester
Yes.
with healthy pregnancies. And it has also been shown that bed rest does not have any significant effect on the well being, rather, it deteriorates the condition of the mother. So, with light work, normal activity, yes, I would add progesterone and get the battery of tests done, and would rather ask the woman to come back in a week where I would like to review, because if a scan is done and as it has been done and it shows that there's a subchorionic hematoma, now at this 6 weeks the placenta is not yet formed. The placenta is going to be formed at the first point of contact of the chorion with the uterus. So if this subchorionic hematoma is on another place where the placenta is not going to form, it will not have a really very deleterious effect. So reassure the patient, give her progesterone, and allow light work and light activity, but with a clear answer that 30% women will continue but others may lose also, and usually the loss is because there is something wrong with the baby, as has been proved that aneuploidies are responsible for a lot of abortions.
Absolutely.
So you prepare her either way and let her go and call her back in a week
Okay, I'd
for a
like to
repeat
invite
scan.
somebody else here. Dr. Rajasi, madam, what are your thoughts? If there is a subchorionic hematoma which you find in such a patient, how significant is that finding?
At this stage of gestation, I think 1.5 centimeter hematoma is definitely significant. And should we admit her? I think I will leave it to the personal choice of the obstetrician, because we are here dealing with an elderly patient. She is obese. She has had a history of weight loss, which is significant. All these factors are kind of risk factors in inciting a threatened abortion. She may progress very well to have a good viable pregnancy later on, or she may abort also. But my line of treatment would be definitely to counsel her that she definitely needs to reduce her level of activity, as in not bed rest, but reduce the exercise, have abstinence, and put her on progesterone.
Thank you, ma'am. So
That's
I
for
think a
sure.
lot of important points have been covered by our panelists. I'll just highlight a couple of important points here. This is a very nice paper which I found, which is published in Obstet Gynecol in August of 2019. Here they followed up nearly 2,500 women over 3 years, of which over 450 had subchorionic hematomas. And they said that the presence of the hematoma itself was not independently associated with pregnancy loss. But having said that, in clinical practice, I'm sure all of us agree that if there is a lot of choriodecidual separation, which may be more than 30-40%, the incidence of this patient
Pregnancy.
losing that pregnancy would be significantly higher. So the theory definitely says that it doesn't matter. But in practice, I'm sure all of us have observed that the theory is not necessarily what happens. We've had an excellent talk by Dr. Ame Purandare on role of progesterone and progestogens in early pregnancy. I'm not going to repeat what has been said, as we have already covered before. Whether it is oral progesterone or vaginal progesterone, as long as there is plenty of PIBF and T helper type 2 response, the chances of continuing this pregnancy are excellent, especially if the patient does not have an aneuploidy. Thank you, Dr. Ashajan, for pointing that out, that the vast majority of first trimester losses may actually be due to undiagnosed aneuploidies, which we obviously have no way of identifying in the first 6 to 8 weeks of pregnancy. And therefore, all we can do is give a lot of TLC, reassurance, follow up ultrasound, ensure that there is good amount of progesterone that's going in. And of course, we need to have some blessings from the Almighty as well. Let's go to the second case. I see Dr. Atul Ganatra sir has just logged in. Sir, good afternoon. Thank you so much for joining in. We'll just conclude the panel and then have you, if that's all right with you. Okay, I think he's gone out to lunch probably.
No, I'm here.
Yeah, okay. Do you want to do your talk now, sir, or should we do it later after the panel? What
Yeah,
would be
I'm
comfortable?
okay. Finish
You're
your
with
panel.
it? All
Finish
right.
your panel.
Thank you so much, sir. Thank you. Appreciate it. So the second case is a 35-year-old lady. She's married since 4
You can
years.
look around and see my face. Can't see me the whole
She's tried infertility treatment but discontinued after a few months. Now she's conceived spontaneously. She comes to you with abdominal pain, bleeding per vaginum. Ultrasound has shown a 7-week intrauterine pregnancy. Cardiac activity is absent. Gestation sac is irregular. Internal loss is already 7 millimeters open. Dr. Swati Sarda, madam, what would you like to do for this patient? I think this is what we call an inevitable miscarriage or a missed miscarriage in technical terms. That is
Yes.
what we would usually call it. But if the patient insists, no, doctor, you wait, do a scan again after some time, how would you like to counsel her? This is why the previous discussion which we had before starting the cases now comes into effect, and this is how you can use that knowledge to counsel this patient.
Yes, sir, definitely. Sir, very clearly it states that it's incomplete abortion because the cardiac activity is absent at 7 weeks and also the internal os is open. So we have to counsel the patient in this manner itself, explaining that this is an incomplete abortion and probably it may not continue into a normal pregnancy. And in, although we can wait, but there are very less chances that it will continue as a normal pregnancy. So definitely we'll have to counsel the patient accordingly.
So already if there is an irregular sac and the internal os is open, maybe
Yes.
within a matter of hours or days, she is going to
Yes,
pass the
correct.
products.
Yes, sir.
And therefore it is necessary to, if possible, admit this patient, do a repeat scan for her whatever mental satisfaction, and when the findings are confirmed by an independent radiologist or by a second opinion, then you counsel her. Now the key here is whether you should go in for a medical termination or whether it should be a surgical termination. Here I would like somebody else to speak. Dr. Kiranbhai, madam, what is your opinion?
Yeah, again, it is, not a official's decision or it has to be counseled and then the decision has to be more or less joint kind of decision. Sometimes patients don't want surgical intervention. Sometimes they want it to be done with in a day and get it finished off without any further this thing. And then we can go for definitely medical or surgical. As such, there is not much difference. Medical method also is quite effective with misoprostol. Only thing is she needs to be under follow-up and has to come whenever it is needed, has to have access to hospital and everything. Otherwise, I think either way we can decide for this case, depending on the patient's choices and accessibility, and that's what I think.
So let me ask Dr. Ritu here. Madam, what would be your choice? Mifepristone, misoprostol, or surgical DNC?
So she's already bleeding and the os is also open. So I would prefer to go for an MVA. You can do a manual vacuum aspiration, which works equally good.
Okay. Dr.
So
Kaveri
that
Shah,
would,
any
and,
difference of opinion?
Sir, I will prefer for MVA or surgical removal because it is precious pregnancy after long treatment they have, and it is coming as a like blighted ovum. So I would like to send this tissue for karyotyping or microarray testings so that we can go ahead with the further future planning of the couple. We can come out with some result and we can plan accordingly and we can guide the couple.
So I've put that last particular statement there on that slide just to throw the cat among the pigeons. Usually we advise abortus karyotyping for a second loss or a third loss. For a first loss, we usually don't advise POCs for karyotyping. But look at the clinical situation. This is an elderly lady. She's conceived with difficulty. She may have a first trimester loss, and we said most first trimester losses occur because of genetic anomalies. So at least if it's possible, and the patient is affording, she is willing, then you can go ahead and do a POC karyotyping. Again, we have to remember that where there is a missed miscarriage, already the chances of the tissues having undergone autolysis is quite significant. But at least mentally you will be safe and you will be happy that okay, you try to get the tissue analyzed and try to identify if there is a genetic anomaly. Quickly, I'll just mention one or two points which are important. We already know that the incidence of anomalies is quite high once the age crosses 30. This is one of the tables which I use to counsel my own patients. At the age of 25, the incidence of trisomy 21, the most common anomaly is usually 1 in 1400. And at the age of 35, it increases to around 1 in 350. If your age is more than 30, you are more liable and more susceptible to have these issues. We've already discussed the benefits of surgical aspiration. If the internal os is already open, it's a quick procedure. But wherever you need to do a sharp curettage and not a simple MVA, always be aware that you will damage the uterine endometrium. And especially in the light of an elderly patient who has difficulty in conceiving, this is something which we would like to try to avoid. If you look at the meta-analysis, then giving mifepristone plus misoprostol, patient aborts very comfortably without requirement of a surgical evacuation later on. Some authorities have tried mifepristone or misoprostol alone, and specifically it is misoprostol alone as compared to M plus M. And they found that giving both definitely results in much better success rates as compared to misoprostol alone. The idea here is to try and not harm the uterine endometrium and the lining, avoid creating iatrogenic synechia and Asherman syndrome wherever possible. The next case is a 35-year-old lady. She's conceived with IVF. Yes, ma'am?
Sir, are we going to take the questions later? Because we have one question in the chat box related to our first case.
Yeah, what is it about?
They're asking the role of ethamsilate.
Would you like to respond to that?
Yes, sir, definitely. We can give a shot, although she's not bleeding, but it can definitely prevent the further bleeding.
The question is about ethamsilate, right? So
Yes.
maybe the question is related to the safety of ethamsilate in first trimester of pregnancy rather than its efficacy in controlling bleeding.
Okay.
I think it's regarding controlling of bleeding. I think Dr. Pratik, quite a few
For
people,
control of bleeding, ethamsulate
yes,
is
they
fine,
do.
tranexamic acid is also fine, but then the question is whether
But I
these
don't,
drugs are
yes.
safe in first trimester of pregnancy. That's a very big question which is very difficult to answer. And then you have to weigh the cost and the benefits, and of course the risks to the fetus, of course. Anybody else would like to comment on it? Feel free to unmute yourself and speak.
I don't think ethamsulate is going to really help if better. I would avoid in first trimester.
Yeah, me also.
All right, thank you.
Not much in favor.
Not much in favor. Most of the panel doesn't like these tryptic agents all that much, especially when they may be teratogenic in the first trimester. So let's go to the third case. This is a 35-year-old lady. She's conceived with IVF. Beta HCG levels have shown an exponential rise over time, which is very typical with IVF pregnancies. If you've seen the beta HCG levels, one day there'll be 300, the next day there'll be 2000, and the third day there'll be 5, 6, or 10,000 even. So they just go on exponentially. An early ultrasound at 6 weeks has shown 2 intrauterine sacs, cardiac activity is present, and now she comes to you with bleeding per vaginum irregularly since 1 week. Can somebody else take this? Dr. Kaveri, do you want to start with this?
So it is her precious pregnancy which has come with twin pregnancy and it is bleeding. So I would go ahead with the first of her investigations. I will rule out any infection, her CBC profile, urine and vaginal infection I would like to rule out, and USG of course is not suggestive any active hematoma inside, but there is bleeding. So I would like to admit the patient since it is IVF and precious one, and I would like to watch as well as I will support with progesterone. Since IVF, so maybe estrogen support and HCG support is required. So I will add that as well. Like that,
So
I
now
would
she
like
is
to
an
manage.
IVF pregnancy. She is already on the usual masala, what we call, including progesterone, aspirin,
And
estrogen, God knows how many other medications, depending on which consultant is looking after her. You did a repeat ultrasound, and this is the ultrasound picture. I count 3 sacs. So at 6 weeks, we could see 2 sacs. Both pregnancies were
yeah.
growing well. Now it seems that this
Now,
lady may actually have triplets. Now
yes.
what should we do?
So first of all, I have to counsel the patient that she may have loss of any of pregnancy or may have complete loss as well because she is already having bleeding. And she has means any of the pregnancy can, because chances of such losses are quite high in such cases if they have a bleeding. And of course, then further that progesterone and all support whatever we were giving.
So now
My
she
main
has
thing
triplet pregnancy. Now we have to carefully weigh the risks and the disadvantages and advantages. In the light of a triplet pregnancy, Dr. Asha Jain madam, what do you think we should try to do?
Sir, this looks, as per the ultrasound picture, this looks like 3 different chorions are in there.
Correct. It's a trichorionic
It's a
triamniotic.
trichorionic pregnancy.
Correct.
Now, you really don't know, the risk of aneuploidy is very, very high in such pregnancies.
Okay.
And we may have to resort to, at 9 weeks, getting a chorionic villus biopsy from each different area and then deciding which one is bad and then, doing a fetal reduction.
Okay.
That is one course of action. Right now, she has come with bleeding. So there is a chance that she might lose all 3.
Yes, there is a very high risk that she may lose all 3.
Yeah.
So does anybody in the panel have any experience of fetal reduction? Rather than ask somebody directly who may not be aware of what is reduction, may not have done it in the past, I want to open this to everybody in the panel because most of us are not ART consultants and would normally not come across a triplet pregnancy. So if anybody has any experience of fetal reduction, can you tell us how it's done, where it's done?
One of my patient, 2 of my patient, they had triplets, and I get them reduced at one of the infertility expert over here, Dr. Chaitanya Shembekar. And I believe he put KCL in the sac.
Okay. Yeah, so KCL is one of the options. I see
Yeah.
Dr. Lakshmi Srikhande is come back. I thought she had left us. Thank you, ma'am, for coming
Pratik,
back.
usually if it is twins, we discourage our couples to opt for fetal reduction. But if it is three and more, that option is there. But we have to counsel them properly. Usually it is done by either gynecologist or radiologist, but you have to have that certificate because we are all doing routine
You need to have the
USGs. We have to
PCPNDT
have
license as a genetic clinic.
special PNDT license. Without that, you just can't even think of doing fetal reduction at your
Perfect.
facilities.
Perfect.
It all depends on the clinical expertise of the person who is doing, but between 11 to 13 weeks, they do a scan and they see which is the weakest one out of the three. And the second criteria is which is easy to do also without touching or without affecting the outcome of remaining two pregnancies.
Easily accessible.
So they do it after fetal reduction. Nowadays, we don't admit our patients. Previously, we used to admit them for observations, but we only counsel them. They have to take rest, tocolytics, progesterone, and of course, we do give antibiotics to them. So this is all about the fetal reduction. Usually in ART IVF cases we see. But
Okay.
nowadays with reduced number of embryos which we are transferring, we are seeing less number of triple pregnancies.
This is the most important point that I want to
Yes.
bring out through this discussion, that the good old days when we used to put three, four,
Three
five,
or
and
more.
maybe more embryos, there are people
Yes.
putting more than that also, are no longer allowed today. There are very clear cut guidelines from various international bodies, including ESHRE, saying that one or maximum two is the number of embryos that we should be replacing in an IVF cycle. Therefore, iatrogenic triplet pregnancy should be something which we should not be seeing anymore 2020 onwards. Having said that, if
It
it
is
does happen, yes, ma'am?
Pratik, it is usually iatrogenic because spontaneous triplets are very rare.
Yes,
But
1 in
in
800.
IUI stimulation also you can get triplets if you are using gonadotrophin stimulation.
Correct.
So each and every gynecologist who is using gonadotrophin stimulation should know when to cancel the cycle.
Yes.
If you are having more than two follicles of 18 millimeter size, please don't give SCG and cancel the cycle.
And please
Many
advise
of the
couple to have
delegates
barrier
ask why
contraception.
can't we give agonist figure and go ahead with the cycle because our patient has spent too much. Please remember you might be minimizing the chances of OHSS, but what about multiple pregnancies? So this is the Lakshman Rekha, more than two dominant follicles in your stimulation of even IUI cycle. Please jot down on the paper that the cycle is cancelled and tell them to abstain from intercourse, natural intercourse as well. So this
Absolutely.
is the
Thank
take
you
home
so
message
much
to
for
all the
those.
gynecologists.
Dr.
I,
Pratik,
Pratik, can I just
shall I add? Yeah,
Yes, Chaitanya.
I think Dr. Chaitanya has joined us. Yes, sir.
yeah,
Please
Yeah,
go
I
ahead.
yeah.
heard you.
Just yeah, Pratik, just one point. As Dr. Lakshmi has rightly said,
Yeah.
gone are the days of triplets. So OHS and triplets you should not see anymore. But just a technical point I wanted to add here,
Yeah.
that there are two situations where two uh, phases where you can do triplet reduction. One is at 9 weeks, and another is at 12 weeks or after NT scan. So the message should be very clear that it is always better to do triplet reduction after doing NT scan,
Correct.
because that is the right time, and then you have to do it abdominally. But I must tell you one more point, that technically it is very easy to do triplet reduction at 9 weeks to 10 weeks, because we do it through ovum pickup needle through vaginal route. So it is technically easy, but ethically and ideally it should not be done.
So most of the radiologists in the past decade have now moved to doing it at 11 to 13 weeks. One more
Right,
advantage is that sometimes because of natural selection, one of the three stops moving on its own. It
right, right.
spontaneously resolves on its own. So then the decision is taken out of your hands. You don't need to perform a termination and land up in all sorts of complications. This is just an interesting paper
Exactly.
I found, which is 27 years of experience of twins and triplet pregnancies. Here they found that nearly 47% of them needed cesarean section, 45% were born preterm. Incidence of preeclampsia increased from 4 to 17%. GDM rose from 3 to 27%, and of course, PIH and PPH were more frequently observed. Therefore, always try and do a reduction from triplets to twins Never reduce from triplets to singleton, because the incidence of that pregnancy also being lost is going to be significantly higher. Another paper from Human Reproduction in 2017, 17 years of data, they found that the incidence of preterm birth reduced from 50% to 17% if you performed a reduction, and the risk of miscarriage did not increase at all. So this is the technical and the medico legal answer. When the couple asks you, can we keep all three? We would like to have triplets. The answer medically and scientifically is no, and this is why. We've already covered the technique, procedure, and everything. So let us go to the next
Can
case.
I, Dr. Pratik, can I
Yes,
just
ma'am.
add one point?
Yes, ma'am.
I mean, at the risk of sounding a little retrograde, now
Yeah.
that we know that we have discovered triplet in this particular case, but
Yes.
if you just look at the question once again,
Yeah.
I would just like to add one point to what the previous panelist has already spoken, that any irregular bleeding PV, you should just have spare 2 minutes and put in a speculum and see.
Speculum
Yes.
Prevent
Local causes.
to
Absolutely right.
prevent any embarrassing situation from the
Absolutely right.
cervix.
Absolutely right.
That is
Thank
a
you for pointing
preliminary
that
first thing that you have to do.
in a panel discussion that needs to be said at some point of time. And that is something which we should always keep in the back of our
Thank you.
minds. Thank you so
Sorry to
much.
interrupt you. Please
No
go
worries,
ahead.
ma'am. Yeah. So this is a 32-year-old. She's a known case of IDDM, blood and urine sugars currently well controlled. She's undergone histolaparoscopy 2 months back, conceived with IUI. Now she's come to you with abdominal pain, missed period, bleeding per vaginum. A very nice triad. Ultrasound is showing you a circular structure, 8 millimeters in the right adnexa, empty uterine cavity. This is not a pregnancy of uncertain location. This is a pregnancy of definite extrauterine location. What should we do with her? Dr. Ritu, can you take this up, please?
Get a beta HCG done first.
Okay, very good.
So obviously, the first thing we want to rule out is an ectopic pregnancy.
Yes,
So get a beta HCG done, and then we decide depending on the level,
yes.
and maybe because
So, how do you
right,
follow up the beta HCG levels? How often do you do the serial HCG estimation?
48 hours we see for the doubling. If it is at least, it should be rising by at least 66% is the normal doubling rate. It should at least 66% rise should be there in 48 hours. If we
Perfect.
don't see, and if it level of around 1500 to 3000 and you don't see an intrauterine sac, so you need to search for a sac outside.
Yes,
And then initially, if you find that, so
perfect. So, Dr. Kiranmai, madam, I want to ask you, if you have an ectopic pregnancy and you don't see cardiac activity yet, it's an unruptured pregnancy. Do you think that this woman can be treated with methotrexate? Is it a good idea?
Yeah. Yes, the criteria to go for medical management of ectopic is one, the patient has to be hemodynamically stable, and the second is, as they say, the sac the size is around less than 3.5 centimeters, beta HCG around 5,000, less than 5,000. And we can definitely go for methotrexate for this patient after baseline investigations, and we would like to ideally admit the patient, or at least she has to have agree to, very clear and meticulous follow-up, and she should be counseled regarding in case if there is any rupture or need for laparotomy, she has to agree for that
So that's
possibility
the most
also.
important thing that we need to ensure, that it's
Yes.
an informed counseling and an informed consent. Patient has to be aware of the implications of a decision. Sometimes patients
Yes.
don't want to get admitted and don't want to undergo surgery, so they will say yes to
Surgery,
anything
and
else
then
you
yes,
say, and then
methotrexate,
they will
very
run away. They'll be
good.
lost to follow up. So that shouldn't happen. Thank you so much, ma'am. Can I ask Dr. Swati, madam, to comment when you should not offer methotrexate to such patients with ectopic pregnancy? Which patients make poor candidates for methotrexate
So
therapy?
if the gestation, the G sac on, if the sac is more than say 3.5 centimeters on ultrasonography, or the HCG levels are more than 3,000 or 5,000, so definitely we do not offer. If there's a cardiac activity present, definitely no. So, and of course the ruptured pregnancies.
And of course, if there is free fluid that is seen in the
Yeah.
pelvis on the
No
first scan,
medication.
then
Yes.
these are the patients who may be slowly
And
leaking.
other contraindications to methotrexate also we may have to consider, I think,
Yes,
the
because
liver
methotrexate
disorders and
itself is a
medical, it
drug.
has some
Yes, and
systemic effects.
absolutely right. Thank you so much, ma'am. Dr. Ashajan, madam, there is one school of thought which says that sometimes you need to give 2 doses of methotrexate. One single dose is not enough. What are your views on this point?
Sir, as you've shown here, there is only a 4% difference in the efficacy, and there's a lot of stress on the part of the doctor and the patient, and in between, and the side effects as well. So, personally, I would not go for a second dose. I would still stick to the one dose, even though it says that you give another dose and the efficacy increases by 4%. I would
So
still stick to the one dose.
in most cases, 1 dose is enough for most patients. Dr. Ritu wants to add something. Yes, ma'am.
Yeah, just a point, sir, because sometimes when we monitor the beta HCG levels on day 4, you may actually see a rise in the HCG levels.
Yes, even
So
after
we
giving
need to be
methotrexate.
just watchful. There might be a slight rise, but that is not because of the increase in the size of the pregnancy. You just have to wait it out, and then you'll find that the titers do start falling. But you need
Absolutely.
to keep a check on the patient.
Perfect. And this is why these patients need to be under observation, or at the very least, they should understand if there are warning signs, then you should come back to the hospital ASAP. Can Dr. Kaveri Shaw, you're an endoscopic surgeon, ma'am. What would be your criteria for choosing in case this patient went in for a laparoscopy? Which patient would you prefer to do an excision, that is a salpingectomy, and where would you like to preserve the tube?
In this patient, like I already taken her for IVF, so I'm not bothered for her tubes right now. So ideally, I can go ahead with the salpingectomies or just ligation of the tubes, because there is a high rate of ectopic once there is, means it's study says that chances of ectopic recurrence is quite high, so we need not to worry about such patient. Of course, if it is not an IVF patient or some other patient and any other such medical history is not there, then I can think of just tubal salpingectomy of one, and I will leave the another tube patent, thinking of other pregnancies and future pregnancies.
Thank you, ma'am. So the RCOG guideline says that if the other side tube is healthy, then you can perform a salpingectomy in preference to salpingotomy. And in case you find that entire big list there, then again salpingotomy is to be considered. We've covered a lot of ground. I think I'll do one last case before I hand over to the speaker. Dr. Alka Mukherjee has raised a hand. Yes, ma'am.
Sir, is there any role of expectant management in these cases when the beta, this SCG is very low and declining?
So let me just reiterate here that this is an IVF patient. She is on high dose basala of progesterone and various other things. The chances of this resolving spontaneously on its own is going to be extremely low. The chance that she will rupture is going to be very high. The chance that she will respond to methotrexate is again extremely low. We just had a theoretical discussion about methotrexate in this patient, but for all practical purposes, patients who have an IVF pregnancy, which has now become an ectopic pregnancy, for whatever reasons, they are not going to be amenable to medical management or expectant management. Surgery will be the methodology of choice eventually, sooner or later, whether it is directly the first choice or whether it is after a failed trial of methotrexate. Dr. Lakshmi Shrikhande has switched her video back on, and she is very anxiously waiting for her turn to speak. Yes, ma'am. Please unmute yourself. Madam, you need to unmute yourself, please.
Pratik, I like your terminology. She's IVF pregnancy and she's on masala of progesterone.
It's a fact, madam. These are patients where we cannot have conservative management.
No, it's a fact, and we are always on the higher side of prescribing progesterones. And in this era of IVF, which is freely available, cost effective, I think we should properly counsel our patients and give them the option of having a recurrent risk of ectopic versus removing the tubes.
Yes.
So gone are those days pre-IVF where you have to conserve the tubes at all cost. So we have to modify accordingly.
Thank you. Thank you so much.
One more thing I would like to add, that expectant management guidelines says that patient should be pain-free, and this patient has come with pain. So I don't think we should offer expectant management, because this is one of the criteria and we should consider it, and patient is complaining of pain. So we should not plan for expected. Ideally, we should plan for surgical.
So let me say very clearly, in the context of fertility treatment, if the patient has developed an ectopic pregnancy, you are not going to win a lot of prizes for conservative management. Therefore, please err on the side of caution and have a low threshold for laparoscopy for these patients. They are
Pratik,
very
you
rarely
rightly
amenable
said,
to medical management.
Pratik, you rightly said because she's IVF pregnancy, we should prefer the surgical intervention because anyway she knows what is IVF. She is undergoing IVF treatment. So if you do surgery and even if you do self-injectomy, I mean this couple is amenable to the repeat IVF procedure. So we don't need tubes for an IVF procedure.
Correct. So, but it's important to counsel the patient and
Yes,
document that
yes.
choice of
Counseling,
method.
written documentation, written
Perfect.
consent. Yes.
Perfect. Let's do one last case. This is a 30-year-old lady. She's referred to us by a local gynec. She had a missed period ultrasound that showed incomplete abortion. Check curettage performed. 1 week later, she is now come back with bleeding again. Dr. Rajasri Sengupta, madam, what would be your differential diagnosis for this patient?
I think I would suspect that there is something incomplete and catching infection and creating trouble thereby. So it would go all in the favor of either the check curettage was incomplete, we still have a few bits of retained POCs left inside, a secondary infection, or an acute and chronic PID, which was a previous chronic PID now exacerbated post-operatively. So I would like to do a
And this is where your per speculum examination comes in. Sometimes the valsalum bite or somebody who uses a tenaculum and the tenaculum sometimes slips during the surgery that is not documented in the notes. Later on that can present to you in similar
definitely
fashion.
injury, definitely.
So also Mullerian anomalies can sometimes present like this. Sometimes you will find that the placenta is in one cornu, pregnancy is in another cornu, pregnancy gets evacuated, placenta or some retained products are still there. And the last and most important point which I
Is the
wanted to
molar
discuss
pregnancy.
is the
Yes,
molar
molar
pregnancy.
pregnancy.
We
Since
need
this
to
is the
do
last
beta
question,
HCG
I'm
also.
opening to everybody and asking you to contribute your thoughts about identifying molar pregnancy post curettage. Anybody can take it up.
Before, Pratik, before going to molar pregnancy, you said she has come back within 2 weeks, right? After the
1 week
check
later.
One
curettage.
week.
Week later.
1 week later. Then again, some amount of bleeding after, check curettage and abortions. What is the exact amount of bleeding after what duration?
It's
Did she
1 to
have
2
any?
pads per day, which is
2 pads.
Yeah,
significant.
yeah. I mean, the normal course of events, it could be nothing. That possibility also has to
It
be
may just
entertained, I
resolve
think.
on its own.
Maybe an
Yeah, I mean,
antibiotic
before
profile
labeling it
for
as one of
2 3 days.
the list which we have in the DD, sometimes, reassurance and there might be nothing exactly.
Correct.
So that is one thing which I wanted to tell. And then molar pregnancy, I've had definitely one case where she was repeatedly admitted for 3 or 4 times with RPOC. Every time she would undergo check curettage and again she would come back with anemia and all. And what was missed was this molar pregnancy, persistent trophoblastic tissue. Her beta HCG was very high and she had to be referred to for methotrexate and chemotherapy also. So that was missed in 2 or 3 places.
So even if you
Everyone was
don't do
taking
an
it as
HCG, even if you don't do
HCG
an
was
HCG,
not
at least do a
ordered.
simple ultrasound,
Yes.
do a simple
HCG, there
speculum.
is, yeah. HCG is if you have a strong suspicion or if she's not responding to your this thing conservative or whatever management you are giving, HCG definitely has a role. I think it's better not to miss rather than not ordering beta HCG. I would definitely go for. I mean, beta
Absolutely.
HCG. There is definitely.
Thank you so much, ma'am. So this is just a quick update I had presented regarding sensitivity and specificity of ultrasound. Even if you don't do anything else, put in the probe. Most of us have an ultrasound machine in a consulting. Look at the ovaries on both sides. Sometimes you will miss those large theca lutein cysts, which will ring the alarm bells in your head that you might be dealing with a molar pregnancy. The discussion of complete and partial is for another day. Vacuum aspiration under good anesthesia and ultrasound control is the order of treatment and the standard of care in today's world. I'm going to stop this panel discussion here by asking all the panelists to share one simple take home message for the audience before we have Dr. Atul Ganatra to speak on his topic. We'll start with Dr. Alka Mukherjee, madam. We are talking about first trimester bleeding. One simple take home message for all the audience.
Proper counseling is must in order to save yourself as well as explaining the patient. It is important that you should counsel the patient in a proper way. What are the chances of abortion? How much? Whether what will happen in her next pregnancy? You have to reassure her as well.
Thank you, ma'am. Dr. Rajasi Sengupta.
Adding to what Alka madam has said, I would put in a physical examination and a transvaginal ultrasonography, keeping in mind all the possible differential diagnoses.
Very good. Dr. Swati Sarda.
Yes, the clinical history and definitely the vitals of the patient would give a certain amount of diagnosis just before going ahead, or we are waiting for the labs or ultrasonography. We can get one certain assessment about the patient.
Very good. Dr. Ritu Darga.
I would like to first take and consider the patient as a whole, whether it was a precious pregnancy or not, and then decide regarding the method of termination. You need to be deciding whether you want to go in for a karyotyping or not. So
Very good point. Dr. Asha Jain, ma'am.
Sir, I would like to see the patient. Don't panic yourself if she is a precious pregnancy, and don't let her be panicked. And do a scan and compare that scan with a previous scan if it is available.
Very important point. We are sometimes so emotionally involved with our patients and their progress that when they start having issues, we ourselves are mentally disturbed.
Yeah, but if she has had a previous scan, then you need to compare with that scan.
Very good. Dr. Kiran ma'am.
Actually, 2 lessons I have learned over the years is don't think 10 times before you label it as non-viable and advised termination. I have had my own close friend who was advised termination because the expert radiologist has felt it was non-viable, but she had persistent vomiting, so just we thought we would wait for some time, and then her son is now a state level player in tennis. So she has had a fruitful pregnancy and all. And another case also. Then the second thing is first trimester losses, early pregnancy loss. Always keep ectopic in mind for any unusual kind of presentation, and also post molar and beta HCG related as well as ectopic. These are the 2 things that I would not like to miss in the early pregnancy loss kind of situations. They masquerade as an incomplete abortion, they masquerade as intrauterine pregnancy, missed miscarriage, but something might be lurking. We have had one case where they have evacuated thinking it as intrauterine pregnancy. Then she had come in shock with ruptured ectopic pregnancy. So
Thank
that
you,
was
ma'am.
missed.
Very good points.
Yeah,
Excellent.
Sir, I would like to add one thing.
Yes, ma'am.
Do a histopathology of all products of conception.
Yes. Ideally, we are supposed to do that. Yes.
Do a histopathology, whether you have to pay it out of your own pocket, do it. Because otherwise, if it is a retained product, if it is an ectopic, if it is a molar, or I had one patient who turned up after 6 months with frank choriocarcinoma. You need to be in these medico-legal climate, save yourselves and also keep your patients safe.
Excellent point, ma'am. Dr. Kaveri Shah, and after that, Dr. Lakshmi Shikhande.
Thank you. In my routine practice, what I have learned that your colleague, whoever is treating, and if second opinion is coming to you, never underestimate your first colleague, whoever is treating, because that opinion really matters. Sometimes you plan that you are heroic, you can do everything, but it can be something dangerous. So be cool, calm, always see the previous records, go ahead with the history, whatever pregnancy is it, whether it is precious or not, every pregnancy is precious, and consider it and explain properly. If it is first trimester bleeding with big hematomas and all, explain very frankly that it can abort, and whatever your previous friend has explained, you need not to be very heroic, just explain very clearly. It continues, it's well and good, but you need to explain first thing. Second thing, suppose it aborts, then, or you are just finishing off this pregnancy, then advise a good contraception, because sometimes they conceive immediately and we don't understand whether it is the first previous that threatened one or what. So you need to advise a good contraception as well, so that the next pregnancy can come out with a better outcome.
Thank you. So good.
In continuation with Dr. Kaveri, sir, in continuation with Dr. Kaveri, I would like to say here If patient wants second opinion, it's okay. But sometimes I also ask patient कि आप second opinion ले लो. Then they are very much convinced कि नहीं आप ही बराबर बात कर रहे हो. तो we will go ahead with the evacuation. Otherwise, it's always better कि आप second opinion ले लो, आप radiologist से sonography करवा लो. These two things that they are very much effective in convincing them कि whatever I am saying is 100% correct.
Good practice points. Dr. Lakshmi Srikhande, ma'am.
Yes. First of all, Pratik, it was a wonderful panel. I will say as usual, because I am used to having a fantastic panels from Pratik Tambe with the inputs from all the eminent panelists. Just 3 take-home messages from my side, Pratik. First and foremost, never underestimate the importance of doing post speculum examination. I will just quote the example of my own patient. She was IVF pregnancy in COVID time. She was not able to reach out to me. She started having bleeding in the first trimester. The gynecologist at her place, without doing PS, advised her to go for termination of pregnancy. So they took out special pass. They came to me. I put in a speculum, and to my surprise, it was a cervical polyp. She was advised to undergo MTP, and I could not believe it. Gynecologists are not doing PS examination. If that patient would not have reached me, this is a real case, she would have ended up by losing that precious pregnancy. So please don't jump that all first trimester bleedings are not only because of the obstetric causes. There can be gynecological causes, cervical polyps, cervical erosion. You have to look for it, and by doing PS examination. Don't be scared. Patient is telling you, I am bleeding, I am not ready to lie down, I will not give lithotomy position. Please convince her and do a post speculum examination. Second, what Dr. Asha said, yes, histopathology should be done, but we can't do it from our own pocket. Better is to counsel them, and if they refuse, we take it in writing from the patients that as a doctor, I have advised the histopathological examination of the products of conception or uterus or ovaries, whatever surgical specimen. The couple, whatever, they are declining. We take their name, signature, date, time, and we put one line in the discharge card as well, so that when they go to the next doctor, they should not instigate, they should not do any jousting, because I explained and they refused. Because histopathological examination in private is not an easy thing. I mean, it's a costly thing. Third thing which Dr. Kaveri said and Dr. Alka said about the second opinion. See, I have really seen, Pratik, the pregnancies where the gynecologist has advised that it is absent fetal heart, undergo evacuation immediately. They have come for second opinion. I sent them to a radiologist for examination, and I can vouch there are so many babies who were advised termination in a haste. I will say in a haste. So please don't be overconfident when you see absent heartbeats on your transvaginal scan. Wherever patient is not bleeding, her vitals are stable, her coagulation profile is normal, please wait for 1 more week. Do repeat TVS on your own, or there is no harm in sending them to a radiologist, because medico-legally then you are more safe that you have a report, printed report from a radiologist. Either it will be a heartbeat present or heartbeat absent. If 2 reports are showing that heartbeats are absent, please go ahead and do the evacuation. So these are 3 important take-home messages on your panel from my side.
Thank you so much, ma'am, and thank you to all the esteemed panelists. We have a fantastic speaker in the shape of our Vice President of Foxy, Dr. Atul Ganatra, waiting, and we don't want to keep him waiting anymore. Can we have the official introduction of Sir up, please? Shrimon. Dr. Lakshmi Srikhande, and if
Yes.
Dr. Chaitanya Shembekar are there, could you please introduce Sir?
It's always a pleasure to introduce our dear friend Dr. Atul Ganatra. He is a hardcore obstetrician. Atul, abhi subah kya kiya? Pata nahi. He must have done some fantastic output to a very, very high risk pregnancy, I'm very sure. And he is currently the sitting vice president of Foxy. He was past treasurer of IAGA, member managing committee of NOGS, and I will say that he is a very, very dedicated, sincere worker for any association he is in. So Atul, the floor is yours. Please start your talk.
Thank you much. Thank you very much, Dr. Lakshmi Srikhande. Always an honor. Madam is kind of a mother figure in Foxy, and I've been to Nagpur. Nagpur is our second home. We have to go to Nagpur at least twice or thrice a year. And I'll start sharing my screen. Is my screen seen?
Yes, sir, your screen is seen, but the presentation is not up.
Yeah. So, Team Amongs, again, it's a pleasure and honor to come in and share our views on some high-risk obstetrics that we do. Yes, Dr. Lakshmi happened to do a very difficult high-risk pregnancy today also. And
I know that you are stuck up means you are doing some high risk.
Yeah.
But I am assured of the good outcome also, Atul, with your knowledge, expertise, and you are so dedicated to high risk pregnancy. I must appreciate it.
Thank you so much. So the first principle, I think this is my mentor, Dr. Nozar Shariar's favorite slide. Premium non, no share, first do no harm. I think that's the basic principle that we must all have when we have a patient sitting in front of us. I work at our hospital and at Fortis, where I'm the head of department, and we happen to see about at least 100 patients referred to us almost every year from our other centers. And this is the example of some of the patients that we've seen from August to December 2019. Hemorrhage with DIC-9, morbidly adherent placenta, classical SES done on 2 patients. Obstetric hysterectomy, maternal mortality in a patient who did not give us a consent, PPH, inferior epigastric artery bleed, and I can go on and on. So I'll just start sharing my experience of a few patients that we did. Time may not permit me to show you all the cases. This is the first case. This is Z, a P2L2 referred to us for having G3 P2L2 diagnosed with placenta percurita. On USG and MRI, history of 2 LSES. She was asymptomatic, all investigations done. Blood arranged, informed consent taken. We counseled the patient extensively right from internal ligation to obstetric hysterectomy. And this is the picture when we took the patient up. You can see on this side here, a part of the placenta jetting out. And what we thought, we were opening the UV fold of peritoneum to remove the baby. When we made the nick, we realized that there was something wrong. We had opened the bladder. So this is how thin the bladder peritoneum was because of the percurita that we had. We stopped at that level, went ahead, did a classical cesarean section, left the placenta in place, repaired the bladder, and then did a hysterectomy on the patient. Every consent was taken. Patient had already had 2 LSESs. A second interesting patient, a dentist, 35.6 weeks with placenta increta, gestational diabetes mellitus on oral drugs, referred to us from Dubai by a gynecologist there. She had history of 1 cervical ectopic, a medically managed, another ectopic, where with methotrexate and embolization was given to her, an open myomectomy, a lap appendicectomy, and a PCOD drilling. 1 lap cystectomy for endometriosis in which the ureter was pulled up. And this is the ultrasound picture, as you can see here, that there was no margin between the lower segment and the bladder. As you can see, the margin here in the upper section, but there was no clear demarcation here in the lower. Again, this is the ultrasound report which shows you the blood flow. This is the picture that we had of the patient when we opened her abdomen. As you can see, these huge vessels in the lower segment. Everything was explained to her, and because this was almost like her 8th or 9th surgery, lower segment highly vascular and placenta bulging and bladder pulled up. We did a classical cesarean section and without disturbing the placenta, as you can see the picture here, went ahead, did an obstetric hysterectomy on her. This is the incision that we made, and this is the rest of the placenta there. Case 3, 30 years old, G4, P1, L1, A1, 1 previous LSES, 21 weeks pregnant, referred with severe bleeding for 6 hours. USC again, placenta, accreta or percurita. HB was 7 grams. Every other investigation was normal. This is the picture at the ultrasound, as you can see, the whole placenta bulging in the lower segment. Patient settled after 1 gram of tranexamic acid. I was just listening to the panel, or somebody asked about giving ethanfolate and tranexamic acid. By the way, tranexamic acid is category B in safety. So it is something that we can use in the first trimester of pregnancy. But patient had another bout of bleeding 6 hours later. Patient taken for an emergency hysterectomy. Mind you, every written consent, and in Fortis, in our bad patients, we do a video consultation and a video consent taking. Placenta was protruding through the uterus. We did a bilateral internal ligation here because this was only a 24-25 weeks pregnancy. We took a vertical scar, brought the uterus out, first did the internal ligation, and then removed the baby by a hysterotomy with a classical incision. As you can see here, again, this is the ultrasound picture where you can see a placenta bulging out from the serosa. Went ahead, did the internal ligation on both sides. The subtotal hysterectomy was done, edges underrun because they were bleeding. Bleeding continued. We put in a Buckley balloon and inflated it for hemostasis, plus put Surgicel and did packing. And the Buckley balloon was removed after about 2 hours. We gave her 6 pints of PRBCs, 600 ml of FFP, and 200 ml of cryo, or 50 mobs were used in this surgery. Here is the picture. You can see that the subtotal hysterectomy picture. And this is the patient 24 hours after surgery who had come to us almost in shock. So this is one thing I would like to say on this platform, that all of us must know how to do internal ligation. I'm going to show you a short video of Professor Khalid, from where I've taken inspiration, from where we have also started doing our own internal ligation. It takes about 3 minutes to do one side. Just listen, see this video. Between the tube and the round ligament. We find it difficult to create a video like this because you don't get prepared. You are not prepared for videos, but this is an excellent video. Your assistant is pulling the uterus upwards and outwards. You could do this just with your fingers. You don't have to use cautery here. Two levers are required, one facing towards the liver. This is to take the ureter away from you. As you can see here, the internal vessel. Use a mixture. This was our target, to hold workshops to train our gynecologists when I took over as Vice President, but unfortunately because of the COVID pandemic, we couldn't do that. But trust me, we've done about 17 to 18 bilateral internal ligations in the last 1 year, and it's extremely easy. We must know how to do it. Most oncosurgeons will take a vertical scar and do it from the posterior approach, but this is an anterior approach, which is very, very easy. It takes hardly about 3 minutes and just 3 instruments. You just need 2 reverse forceps and 1 good atraumatic forceps to pick up the internal artery, and a mixture. So that is not very, very difficult. It's just the fear in our mind that has to go. Another patient of central placenta previa, where we did what is called as took the patient to the cath lab and put in a balloon through the femoral artery. As soon as the baby was delivered, the balloon was inflated to occlude the internal arteries, and then we kind of removed the placenta. But in spite of having occluded that for about 2 or 3 minutes, the maximum you can occlude is for 5 minutes. The patient persisted to bleed, so we put in a Bakri balloon, sutured the lower segment above it, and then removed the Bakri balloon after about 48 hours. These are different types of balloons available. The Ebb Complete Tamponade, which has the vaginal and the uterine balloon. I think we must have some of these in our OT all the time. Another important message that if you have a nursing home setup, we must have this aortic clamp made by Dr. Paili to occlude the aorta in case you have intractable bleeding and you do not have enough blood. And according to Dr. Paili, it is very, very safe to occlude the aorta for up to 40 to 45 minutes in the process where you are waiting for blood. So resuscitation with fluid and blood products, standard surgical procedures, pressure on the bleeding site, infrarenal aortic compression, aortic clamping, direct pressure on the percreta should be avoided or applied cautiously as it may increase the bleeding area, and a massive transfusion protocol has to be followed. I think this is important steps that we need to remember. This is another patient who was referred to us post LSCS, about 12 hours post LSCS. She had undergone an elective LSCS with a very, very senior gynec for severe PIH, referred in severe shock on ionotropic supports. On admission, pulse was around 35 per minute, BP 70 systolic. Per abdomen, there was a large mass felt in the anterior abdominal wall, no active bleeding. Patient resuscitated, stabilized. Ultrasound was done, which showed a huge rectus sheath hematoma, uterus postpartum, no intrauterine collection. There was frank hemoperitoneum. Her HB was 4.2, her pH was 6.8. Remember, anything less than 7 is not compatible with life. INR was around 2.8. She was not in any position for us to go in and operate. Her lactates were 17. A provisional diagnosis of hemorrhagic shock with severe acidosis was made. We took her for a CT angio, which showed a bleeding vessel. Went ahead, did embolization of that vessel. Her inferior epigastric artery also was leaking. This is the CT report, as you can see, and you can see a bleeding vessel over here. Went ahead and did the embolization, stabilized her. After 48 hours, when she settled down, we went ahead and evacuated the hematoma, but that was not it. When we saw her on the first day, we saw a little bluish discoloration in her arms, which was pointed out to the relatives. And as you can see here, within 3 days, the hand was completely thrombosed and the skin over it went away. She was given inotropic agents like NORAD from an IV line, which was not in proper position, and that caused extensive damage to her dorsum. A reference was given to the plastic surgeon, diagnosis of a left hand compartment syndrome and a reperfusion injury. Fasciotomy was done, and subsequently went ahead and did about 4 or 5 plastic surgery procedures till she settled down. So important message here, if you have a patient who is in shock, an experienced senior person should take the IV line, and before injecting drugs like NORAD, you must see to it that the IV line is patent. Otherwise, sometimes you can see fatalities like this. You can see here there was complete occlusion of all her vessels when the IV had gone out. Inotropes like NORAD are vasoconstrictors. You can see this is the situation of the hand. Eventually, multiple surgeries she had to undergo, flaps and a repair and plastic surgery flaps. If that was not enough, day 12 she had an intestinal obstruction and we had to kind of do a visualisis. After 1 year, she developed an incisional hernia of that area, and again a hernioplasty had to be done. Another patient of IVF conception on heparin, posted for LSCS. One of my own patients recovered. Post-op, she started developing severe bleeding, went into shock. We did an exploratory laparotomy, Bielench and Cho sutures, and bilateral internal leg artery. She happened to be my OT secretary's sister, and unfortunately, she settled down. These are some Bielench and Cho sutures. This is another case of a patient who underwent an LSCS outside and was referred to us 6 hours later saying that she had a reaction to a drug called diclofenac sodium. And that's what the physician told me. But when we saw her HB was 5 grams. You can see the condition of her abdomen. She was pupils fixed and dilated. We said that the only chance to save her was to do a laparotomy. However, it took us about 2 hours of resuscitation to bring her back blood pressure back to 60. But and they wanted assurance that nothing would happen to the patient. Mind you, the patient's pH was just 6.4 and the lactates was 17. We said we cannot promise anything. They did not give us consent. Unfortunately, we lost the patient because of the negative consent. We could have saved her, but we did not know how much damage we could have caused to her because she was about absolutely with no blood pressure, that could be palpable blood pressure for up to 2 hours. We gave her 9 PRBCs, 10 cryos, 10 FFPs, and 1 SDP before the blood pressure came up. And actual blood pressure, hemoglobin, when we realized on the ABG, it was around 2 grams. So I think timely shifting of the patient is very, very important. Another patient of post-cervical encephalitis sepsis. She probably leaked somewhere at home and didn't realize. 18 weeks with frank pus discharge coming from the os with fever of 5 days, cervical stitch removed. A misoprostol was inserted before she was sent to us vaginally. USG IUFD at about 15 weeks. Anhydramnios, os tightening was done 20 days ago. She had a fever of 103. She was tachypnic, tachycardic. Total count was 52,000, CRP 93.6, procalcitonin was 4.3, which is supposed to be 0.05. We went ahead and did a hysterectomy because she was in real sepsis, placenta macerated, adherent. Sorry, hysterotomy, not hysterectomy. 2 PRBCs transfused, sent the tissue for culture, which grew E. coli. This is the macerated placenta. This is one place where the minute we opened the lower segment and I was trying to mop the lower segment opened up with my fingers. I did not have to use a blade. And that is the kind of septic shocks he was in. Another patient of help with press was referred to us, 25 weeks pregnancy, which started with blurring of vision and subsequently had complete loss of vision when she came to us. Gross hematuria, BP of 200 by 100. Referred as impending eclampsia with HELLP syndrome and loss of vision, BP 170, 110. I think her albumin was 3 plus. She was in HELLP, SGOT 1069, SGPT 529, platelet count 31,000, creatinine 1.63 plus albumin. MRI showed posterior enhancement, which means that she had press, and as a result of this press, she had lost her vision. We went ahead, delivered her, and the vision came back after about 7 weeks. Case number 9, the orders could be wrong. Patient was referred to us with dengue and IUFD with a massive rectus sheath hematoma. HB was 4.4, 2 PRBCs transfused outside, CT angio done, 30 centimeters of a hematoma collection seen on the CT angio. As you can see here, this is the IUFD. This is all the collection that she has. Right rectus sheath 8 by 5 centimeters hematoma. Again, a Foley's catheter was inserted intracervical to deliver her. HB dropped to 6.1. Correction was given. Did a laparotomy and evacuation of the hematoma. 2.5 liters and inferior epigastric artery bleeding was controlled by ligation. Give her 6 PRBCs, 2 FFPs, 1 SDP and 2 RDPs. This was post-dengue, spontaneous right inferior epigastric artery. So I think sometimes we need to think out of the box in these patients. I think a proper evaluation, proper examination of the patient, extremely important. This is the picture, and this is the picture of the hematoma that we got at the end of surgery, and see the abdomen of the patient. I can go on and on, but I think for want of time, I would like to say never stop doing your best just because someone doesn't give you credit. Number 2, know yourself, know your limitations, or refer the patient to a place where everything can be done under a single roof. Finally, the Boy Scout motto, be prepared. Please be prepared at all times because obstetrics is bloody business. Thank you very much.
चैतन्य होतं ना, कुठे गेला चैतन्य? युअर कन्क्लुडिंग रिमार्क्स.
I think he's facing some poor network issues now.
Yeah, he just called us now. He was trying to log in, but because of the net issues, he's not able to log in.
And then one hardcore obstetrician to give comments on another hardcore obstetrician's talk. Atul, as usual, well done. You are the master in managing the high risk cases.
Thank you very much.
If there are any questions, Pratik will take.
There are no questions from the audience, but in case the chairperson or chairpersons, if they are present, have anything to ask, please feel free. We have 5 minutes before we close and offer the official vote of thanks.
अतुल सुबह कौन सी केस किया बता और घर में बैठा है क्या इतने फोटो पीछे लगे
Yeah, घर पे आ गया हूँ because patient
पे आ गया हाँ
OP छोड़ के आया हूँ जल्दी because I wanted to just kind of gather all the cases out of the 50 cases. थोड़े से ही cases मुझे दिखाने थे.
इसको भी खाकरा खाना होगा अगला फीगो का ट्रिप अतुल के साथ में करना हाँ फीमेल्स को अन्नपूर्णा बोलते हैं मेल को क्या बोलते हैं जो ऐसा कंटिन्यूअसली खिलाते रहे कितना सारा लाया था गुज्जू बाप रे और ऐसा निकालता था वो बैकपैक में से अतुल भूख लगी ऐसा निकालता था बहुत अच्छी मेमोरीज है मेरी नेक्स्ट वाले की फीगो की बुकिंग हाँ अतुल ऑस्ट्रेलिया चलेंगे
Absolutely.
So I would like
कोरोना ने सिखा दिया है सब कुछ घर पे करना पड़ेगा खाना बनाना भी पड़ेगा
अच्छा
सब
तो अगली बार अतुल बना के लाएगा मिसेस को तकलीफ नहीं देगा क्या बात है सीख गया खाना बनाना अपना ऑब्स्टेटिक करते करते Good.
So, as the convener for today's program, it is my pleasure and privilege to present the official vote of thanks. I'd like to place on record my gratitude to our AMOG's office bearers, our President Dr. Nandita Palshetkar, Secretary Dr. Arun Nayak, for always being there for us, supporting, promoting, and encouraging us. Thanks are also due to the Chairperson of ICOG, Dr. Mandakini Meg, Secretary ICOG, Dr. Parag Biniwale, for granting us ICOG credit points for this event. My thanks to the 4 chairpersons for today's event, Dr. Kiran Kurtakoti, Dr. Lakshmi Shikhande, Dr. Vaidhi Marathe, and Dr. Chaitanya Shembekar for doing a wonderful job. 2 fantastic talks by Dr. Amay Purandare on role of progesterone in recurrent pregnancy loss and the high-risk obstetrics experience, which is probably unparalleled, by Dr. Atul Ganatra. Thanks are also due to all the wonderful panelists and the way they contributed to our panel on first trimester bleeding. I'd like to express my gratitude to our academic partners for today, Bharat Serums and Vaccines, and our scientific backbone, Science Integra, Subbu, Shrimon, Seshan, Meenal, Sana, all of you. Thank you very much for being there with us. Thank you so much, audience. We have nearly 500 people logged in even now for being here on a busy weekday afternoon. And we hope to see you very soon in the near future. Goodbye, God bless, and stay safe. Bye for now.
Thank you so much to Pratik for being a wonderful convener and moderating the session from beginning to the end. Thank you, Pratik.
Only time I've come home so early, Pratik. Thank you so much.
He has got the magnetic power. Now we all get attracted when Pratik invites. We all come.
Bye. Thank you.
Thank you so much, everyone. Take care. Stay safe. Bye for now.
Thank you so much, sir.
Bye, everybody.